So all of you are aware that we have a problem with opioids in the United States. It has appropriately been called the opioid epidemic. And the reason it's called the opioid epidemic is that opioid overdose has surpassed trauma and a number of other things as one of the leading causes of death in the United States. Last year, 55,000 people in the US died of drug overdoses. About 40,000 of those were from opioid overdoses. Way more than guns or motor vehicle accidents or other things that used to be number one as far as the leading cause of death in people under age 45. Why do we have this problem? Well, I give hour-long lectures on this. I'm not going to do the entire opioid rant, but I will tell you one statistic that points out why we have this problem. The US consumes 83% of the world's opioids. So the reason we have an opioid problem is we think opioids work a lot better to treat pain than any other country, which is why we prescribe way more than any other country. There's virtually no other country except Canada, and the problem with Canada is it's too close to the US, so some of this stuff of opioids is seeped into Canada. There's no other countries except the US and Canada that actually use opioids to treat chronic pain. And I, in the course of my career, because most of the pain that I have treated over the course of my career is fibromyalgia pain, I have never newly prescribed an opioid for someone to treat their chronic pain. I've refilled prescriptions occasionally for opioids, but in a 35-year career of taking care of chronic pain patients, I've never, ever newly prescribed an opioid saying, I want you to use this for chronic pain, because up until the 80s or 90s, the mantra in the United States was, they don't work, and we shouldn't be using them to treat chronic pain because there's no evidence they work in chronic pain. Well, then a whole bunch of things happened, led by the pharmaceutical companies that have been evil in this regard, that led US physicians to start to think that opioids were more effective to treat chronic pain than they really are. And then we also started prescribing way more opioids to treat acute pain. So we use a lot more opioids after surgical procedures and things like that than any other countries do. And so you add those two things together. We use opioids for chronic pain when no other countries do. And we use a lot more opioids for acute pain than any other country does. We use 83% of the world's opioids, even though we have 3% of the world's population. So this is the problem. And the opioids are everywhere. And when they are everywhere, they end up getting diverted, misused, and things like that. And then people get addicted to them. They start... About 3/4 of the people in the US that are addicted to heroin started on a prescription opioid, because there's so many prescription opioids that someone takes out of a medicine cabinet from someone that got a big prescription for opioids after their knee replacement surgery and only took 2 out of their 90 Vicodin. But if that is sitting in your medicine cabinet, in case you don't know that, you might as well have a loaded pistol in your medicine cabinet, because that is how dangerous those unused opioid prescriptions are, because these unused opioid prescriptions end up getting taken by a teenager, a friend, or a family member. They're either given to or sold to someone else who then gets addicted to a prescription opioid. And on the street, the cheapest opioid is heroin. It's way cheaper to get heroin per unit high on the street than it is to buy Vicodin on the street or OxyContin in the street. So what happens is someone gets addicted to a prescription opioid. They switch over to heroin because it's a cheaper opioid for them to get on the street to fuel their addiction. And then one day someone spikes their heroin with fentanyl or even worse, and they don't wake up the next morning because that leads to an overdose that makes them stop breathing. So that is the public health problem associated with opioids, and that bothers me. But what bothers me more so as one of the world's leading pain researchers are the large numbers of patients taking opioids in the United States for chronic pain that think that the opioids are helping their pain. But when we look at them as a physician, as sort of a neutral third party, we actually think the opioids are harming them more than they're helping them. But that patient believes, because the opioids did help them for the first couple months that they went on the opioid, that patient continues to believe that the opioids are helping them, even though we don't see any evidence of this. So let me do a bit of a cognitive exercise here, because this is really important. If you are taking an opioid regularly for your chronic pain, I am talking to you for the next 5 minutes. And when I say this, I don't care if you're using a drug like hydrocodone, a couple times a day on a bad day, and then the next day you don't have to take it at all. If you're using it on an as-needed basis and it really helps during flares of your pain or things like that, I don't have any problem with that. The problem I have are people that started out on an intermittent use of an opioid, went to a regular dose of an opioid, and then slowly, gradually increased their opioid dose over time because they thought the opioid was the only of their drugs that was helping them. What I want you to, if you are in that category, if you are taking an opioid regularly for your chronic pain, I want you to do a little bit of an exercise with me. And I want you to go back and think of what your pain level was when you first started taking an opioid, if you just use a 0 to 10 pain scale. And even more importantly, I want you to think of what was your functional status when you first started taking an opioid. And by functional status, I mean, what could you do in a day, or what could you not do in a given day when you were first started taking an opioid? And so this might have been 5 years ago, 3 years ago, 10 years ago when you first started taking an opioid. But I want you all to think of what your pain level was and what your functional status was. And then what I would like you to do is fast forward to present and compare your pain level now to your pain level then, and your functional status now to your functional status then. So if I was your treating physician, I would do this. And if you weren't able to look me in the eye and say, my pain is better now than it was when I first started taking the opioid, and my functional status is better now, I can do more in my day-to-day life than I could when I first started taking an opioid. If you can do that, if you can look at me and say, my pain level is better and my functional status is better now that I'm on a regular dose of an opioid and I've gradually increased the dose compared to when I first started taking an opioid, I don't care if you take an opioid. You might be one of the people that I refer to as unicorns, who actually are getting benefit from opioids for their chronic pain. But I don't see that many unicorns. The reason I call it unicorns is that when I see people that have chronic pain that are on opioids, I see that they're coming in, their pain levels are 8 or 9 out of 10. Their pain isn't in any way well controlled. Their functional status is crap, that they're not able to do anything. They basically sit around the house all day because they're not functional, they're not able to do anything. And this aligns with how opioids work to treat pain. The way opioids work to treat pain is they dissociate you from the unpleasantness of your pain, but they also dissociate you from life. And so when people take enough of an opioid to treat their pain, it often dulls them to other things that give them pleasure in life. It often dramatically decreases their functional status. And this is why those of us that are thought leaders in the field look at these patients and say, you need to think about tapering off of your opioid, because we see that when people slowly, gradually taper off of opioids, there are usually only one of two things that happen. Either the pain stays about the same, or the pain actually gets a little bit better when you taper off the opioid, rather than what you all think would happen is if you slowly tapered off of your opioid, is that the pain would get worse. Or the opioids, you're at a high enough dose that you are at risk of not waking up the next morning. Because if you take, the problem with opioids is that they depress breathing. The problem is so does alcohol, so do drugs like Valium or Ambien or other drugs like that. What usually happens that cause a fatal opioid overdose is someone takes their constant dose of opioids, and then they take a little bit of alcohol or a little bit more of their Valium or their Ambien or whatever, and that's just enough, because those other drugs also depress breathing. That's just enough for them to not wake up the next morning. And I'm not trying to frighten people here. These are that a lot of those 35 or 40,000 people each year that are dying of opioid overdoses are chronic pain patients. What you're seeing in the newspaper are the people on heroin, are the addicts, or things like this. But this happens to chronic pain patients, especially if you have slowly, gradually gotten up to the fact that you're taking over 100 oral morphine equivalents of opioids a day. This is the line where we've seen that level can cause death and other really serious complications, even amongst people that have chronic pain, not people that are abusing heroin. So the bottom line here is that people that have chronic pain need to understand that there's been a tremendous sea change in the field of chronic pain. Is that when we were more permissive and we allowed the opioid manufacturing companies to aggressively market opioids, and we sort of went along with it because it was like, well, if these work to treat chronic pain, then we'd like our patients with chronic pain to have these drugs. As we've seen the consequences of that, the pendulum is rapidly swinging the other way. But there is a moral here in the story for you as an individual patient, in that if you are on moderate to high doses of opioids and you have chronic pain, and you can't very clearly tell me, yes, I'm one of those unicorns, that they really have helped me, they really make a difference, they really have changed my functional status, and they make the difference between me being functional or non-functional. If you're not a unicorn, you need to be thinking about lowering your opioid dose just to see how you would feel and see the extent to which they either are helping you or maybe they're harming you in ways that you're not aware of. Let me just talk about medical marijuana and cannabis for a minute. So a lot of states, including Michigan, have either signed medical marijuana laws or enacted medical marijuana laws, or actually even have legalized marijuana. And along with this, there has been accumulating evidence that medical marijuana or cannabis can be an effective drug to treat chronic pain. And in fact, just in the last year, there have been a fair number of meta-analysis reviews, blue ribbon panels, one that came from the National Academy of Sciences in the United States, that concluded that the weight of the evidence now supports the fact that cannabis can be an effective treatment for chronic pain. So that's all good. That's theoretically good. It's another treatment for chronic pain that is now available to people in more than half of the states in the United States that either have medical marijuana laws or have legalized marijuana. What's the bad part? Well, there's a whole bunch of stuff that's bad about this. Number one is that most states' medical marijuana laws are not really medical marijuana laws. Our law in the state of Michigan is a law that was written by potheads for potheads. And the overwhelming majority of people who have the medical marijuana cards in the state of Michigan are recreational users, not legitimate medicinal users. Now, that's not so bad. Is that one of my favorite sayings in life is that even a blind squirrel gets a nut once in a while. So if someone passed a law that was intended for one reason, but it actually ended up benefiting legitimate chronic pain patients, that's not so bad. The thing that I really dislike about the law that was passed in the state of Michigan, as well as the laws that were passed in most states, is they didn't have any provisions for educating patients and physicians about how to use medical cannabis to treat chronic pain. And for that reason, a lot of physicians don't see a lot of pain patients that are getting a lot of benefit from cannabis because no one sits down with them and talks to them that if you want to try cannabis to treat your pain, this is how you should use it, these are the principles you should use, and you're totally flying blind. It would be like me giving you 200 Vicodin in a bottle and not giving you any instructions on how to take it. It doesn't say how many to take a day, what dose to take, or whatever. I just give you 200 of them and say, this might help your pain. And you might take 10 at a time, you might take 0, but you'd have no guidance whatsoever in what's the right dose, what's the right strength, what's the right route of administration. So I'm going to give a really quick lecture on if you are going to use medical marijuana, which if you have pain that is coming from your brain as a result of attending this lecture today, it is a very reasonable option, which is why it's in the second level of evidence here, is cannabinoids are in the second level of evidence. If we had a cannabinoid that was a synthetic cannabinoid that was approved for use in pain in the US, cannabinoids would be here on the top of the list. So this class of drugs works fairly well. The problem is, in order for you to get this class of drugs, you have to ingest or smoke a weed that I don't know the strength of, the dose of, the strain of, the whatever of. And for those reasons, that's way less optimal and that's way lower on the list than something that I do know the dose of, the strength of, and things like that. But having said that, I give lectures all over the world saying that I think medical marijuana for treating chronic pain should be below everything else that we use but above opioids. And I've written editorials in the Free Press, in scientific journals, and in a lot of other settings making this case. And I debate people often making this case. And I never lose the debate, because if you just look at the data, if someone landed from Mars in the year 2017 and looked at what we now know about opioids in chronic pain and looked at what we now know about cannabis and cannabinoids in chronic pain, I am quite comfortable that cannabinoids would be approved by the FDA, opioids would not be approved by the FDA, but that is not how historically we got to the year 2017. So right now, because of the historical precedent, we have a mismatch, is that US physicians and our regulatory agencies are more pro-opioid than they should be and more anti-cannabinoid than they should be based on the current evidence and data. So let me give you some really simple, helpful hints that if you are going to try medical marijuana, how you should try it. So the first thing is you should somehow take it orally rather than smoke it. Because any drug that we're taking or having someone take for a chronic condition, we want it to go up slowly, stay at a good level, and then go down slowly in the system so that people can take it a couple times a day in order to get relief of their pain or their other symptoms. If you smoke marijuana, your level goes up very rapidly and comes down very rapidly. And so you would have to smoke 15 or 20 times a day to keep the marijuana levels high enough for you to continue to have an analgesic effect. But that wouldn't be the worst thing about smoking 15 or 20 times a day. It's sort of annoying if you have a job, you have to go outside and smoke 15 or 20 times a day. But the worst thing about smoking 15 times a day is every time you smoke marijuana, that level goes up really high in your brain and it makes you high. So a lot of what makes you high when you take a drug is the route of administration. So all drugs of abuse are smoked or snorted or injected because the more rapidly that drug goes up in your brain, the more likely you are to get high. The reason we use the drug methadone to keep people off of heroin. Methadone is an opioid just like heroin, just like morphine. All those drugs bind to the exact same receptor in the brain. The reason we give heroin addicts methadone to stay off of heroin is methadone is an oral form of an opioid that takes a long time to act and then acts for a long time for an entire day. And so when people are on methadone once or twice a day, they don't crave opioids, but they don't ever get high. Because the oral form of the opioid that goes up slowly and stays at a level and then goes down slowly doesn't make them high. And that has also been shown with medical marijuana and cannabis, is that if you ingest cannabis as an oil, as part of a food, as a tea, in any number of ways, it is way less likely to make you high. And when I am giving recommendations about medicinal use of marijuana, I don't want you to get high like I wanted to get high in the 70s when I was using recreational marijuana. And one of the things that makes my head explode when I do debates about this topic is that people always conflate recreational use of marijuana with medicinal use. And I say, well, why are those two things connected? You know, why, in the old days when doctors used to be more positive about opioids for treating chronic pain, I didn't have to explain what was going on with the heroin epidemic in the United States in order for me to justify using an opioid clinically. And I don't necessarily think it's a good idea to legalize marijuana or for recreational use of marijuana. I think I have a lot of legitimate concerns as a neuroscientist about recreational use of marijuana, especially in younger individuals. But that's not what I'm talking about. I am a chronic pain physician. I'm talking about a field where one by one, a lot of our other drugs have been thrown by the wayside because they have side effects that we didn't know about or because they don't work nearly as well as we thought they did. And I'm a pragmatist at the end of the day. So if you've tried everything else and the last two classes of drugs that you have an option of trying are either a cannabinoid or an opioid, I would highly recommend you try the cannabinoid. Start with an oral preparation. Start with a low THC to high CBD ratio of cannabis, because it's the THC that makes you high, whereas the CBD doesn't make you high. And then start at a really low dose of that and go up very slowly. The biggest problem with the edible cannabinoid preparations, the cookies, the brownies, the oils and things like that, is that if you are a cannabis virgin, i.e. you haven't used marijuana recently, and you use one of the current strains of marijuana, you eat one of those cookies and you are going to be hallucinating for a day. If you ever read Maureen Dowd, the New York Times columnist, she wrote a column a couple weeks after Colorado legalized marijuana, and she ate a marijuana cookie and sat in her hotel room and hallucinated for about 8 or 10 hours, is that these are really, like an entire cookie is about 10 times more than any of you should be taking if you are a new marijuana user and you've never used it before. So this is really the big thing people have to be careful about, is the current marijuana strains are really high in THC. And if you do get access to one of those edibles, either an oil, a cookie, or whatever, start at a really low dose and go up very slowly. And then the last thing I would say is that a lot of people who use medical marijuana are using it as an opioid-sparing drug. We published a study done at a medical dispensary in Ann Arbor last year that showed that when people started using medical marijuana to treat their pain, on average they lowered their opioid dose by 2/3. And they felt a lot better when their pain was largely being controlled by the cannabinoid than they did when their pain was largely being controlled by the opioid, because the cannabinoid has less unpleasant side effects, that's why people like to use it recreationally, than opioids do. But the two things that we noted, and that has been shown in other studies that have been done elsewhere, is that cannabis is probably a legitimate opioid-sparing drug that people can use as a way of lowering their opioid dose. It can be a really helpful, really effective drug for people. If they start at a low dose, they go up very slowly. The last thing I would say is start by taking a single nighttime dose of the cannabis, because a lot of people that use cannabis and that have integrated it into their regimen find that that dose is really helpful because it helps them sleep in addition to helping improve their pain. So that's my cannabis lecture. I'm not as much an advocate of medical marijuana as I am anti-opioids, I would have to say. And if I wasn't practicing in a country that had such an opioid problem, I wouldn't probably not be quite as positive about cannabinoids. But I really do think they're a far safer alternative than opioids. And there's a lot of evidence that they actually work in conditions like neuropathic pain and fibromyalgia that opioids actually don't seem to be effective in.